Hi everyone, I'm Dr. Faisel Syed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care. Today, Faisel and I are recapping this year's annual Primary Care for America event, discussing PrimaryCare24, See the Possibilities. Let's get started.
Well, hello, Dr. Dan. How are you doing?
Good, Faisel. A little bit tired after our quick trip to Washington, D.C. for Primary Care for America.
I'm so excited that we were able to attend and participate there and record a live podcast episode. I never would have imagined that could happen.
Absolutely. I think Liz Fowler from CMMI was just so gracious in agreeing to do the live podcast and really think it will be interesting to the people who didn't get to hear it live. So I think some of our listeners may have already heard it when they're listening to this.
Today, our plan was to discuss the highlights from the annual Primary Care for America meeting, but the theme this year was seeing the possibilities, and the main focus of that, to me at least, I mean, I was only there for a short while, but the theme that I heard over and over, whether it was the direct primary care panel, or really, even when we were talking with Liz Fowler, the focus is like, hey, how do we restore the sacred doctor-patient relationship again?
I think you're right. I think in listening to Andrew Bazemore talk, he was talking about that it was you had to have access and continuity of care, right? I think you're absolutely right. It is about the relationships. Jim Collins, in his book Built to Last, talks about the genius of the and the tyranny of the or. And so you can have access and continuity. It takes some work to do that, but you can also have a close relationship and have the ability to have technology help drive the care forward, or the close relationship and the team helping support that. So it really is, in my mind, it was about the and, how to keep what is precious in that doctor-patient relationship and provide access to more people to have that relationship with their doctors.
Why do you think the relationship has deteriorated over these last 15, 20 years?
I don't know that the relationship has deteriorated. I think the funding for primary care has not kept up. There was an interesting panel on the RBRVS and the RVU system. They talked about originally it was designed to value the procedures more than the thinking part of the process. And it's going to take some serious technology to make it work going forward. The other thing is what have we been studying? Yalda Jabapour was talking, and as I recall, her figure was 0.3%, 0.3% of research dollars from the national level is spent on primary care. Yet we know that primary care is the only specialty that improves outcomes and reduces costs. And you'd think in an economy where we're spending over $4 trillion a year in healthcare that we would be thinking about how do we do this better and how do we figure out how to support the primary care providers who are doing this work.
You would think so. And when things like this that you're saying that make so much sense don't make sense, my father would tell me, well, you got to follow the money. Somebody's benefiting from the costs going up. And if it means that the primary care doctors are the ones having to carry that burden, until some major policy changes are made, it's just going to keep on. I mean, one of the points that came up was, I think it was from Dr. Fox, about how we were told that technology, the promise of the technology, right? Promise of the technology was supposed to enhance be an extension of the doctor-patient relationship. And then instead now the burden of just the documentation of all the interactions, it's become a barrier to the relationship. So I'm glad that those points are coming up more frequently, front and center. Like, hey, we're just calling this out. It doesn't matter what someone is trying to promise so far as the technology is concerned. Hey, we're past that point right now. Okay, we we were sold these, this bill of goods, and it has not come to fruition. But the good from all of that is hearing how creative people are getting, right? I mean, look how creative doctors have become. Who would have thought that the direct primary care movement? Very inspirational to me.
There was one, Kate Goodrich, who's the chief medical officer for Humana, was talking about her mom, taking her mom to the doctor. And she said, my mom has a really good primary care physician that's working in a really bad system. And my mom is not getting that grade of primary care. Some quote like that. But there were some bright spots there, right, Faisel? So what were the bright spots that you took away from there?
We hear all the time about the problems with the payment system, and we know there are a lot of persistent, smart people working to make some positive movement with the payment models, and there are persistent, smart people trying to make the technology less of a barrier to doctor-patient relationship. But to me, every year that we come out to one of these conferences that's highlighting the bright spots, to me, the model that is standing out is the direct primary care model. I mean, every year, I'm just increasingly impressed that this very simple concept that was born out of necessity and frustration, all the terrible issues with the current models, look how it has grown. Just really to simplify, make it very easy for people to be able to access their doctor, and for doctors to be able to have that relationship with someone who wants to have a trusting relationship with their physician. And then from that, the rise of the direct to employer models, which is also very exciting. I mean, the cost of medical benefits for a family of four used to be $2,000 or $3,000 20 years ago. Now it's way north of $20,000. Somebody just told me that at their company it's over $30,000 to insure a family of four now, right? And so the direct primary care model, the direct to employer model, didn't come from a policymaker in Washington. This was born out of family doctors who could look after children, family doctors who could do women's health, family doctors who could do procedures, family doctors who could do complex chronic disease management.
Right. But, the other thing we saw there was the direct primary care, the different models of direct primary care didn't necessarily agree with each other. And Mark Tomasulo, who's the head of direct primary care strategy and innovation for One Medical, he talked about the analogy that you have fee for service over here, which is pure fee for service is broken. You have direct primary care over here, which is immature, and they've got to move towards each other, right? So it's not enough. We can't just say that we're going to do one or the other. We got to figure out how to move them both in the direction of providing more value, and have to use payment reform support for the teams and technology to do that.
Yeah, I love that. Okay, we've got one extreme versus the other. And the fee for service world, with all the data and the collection of data and the reporting of all this data that most of us in primary care don't really find helpful. But that's not to say that there isn't data that's useful. I'm just saying that a lot of it, we kind of look at it, kind of shrug our shoulders. Oh, okay, and now what do you want me to do with this?
Right.
But they take that frustration and then they go, you can't go to the other extreme and say, well, we shouldn't be collecting any of the information at all. And so that was very refreshing to hear. Well, listen, we need to be able to speak that language so that we can start sharing these wonderful health outcomes. Because a patient maintaining the monthly payment to the direct primary care practice alone should not be the benchmark. Well, hey, the patient's still paying the monthly membership. I got to be doing a great job. Well, there are a lot of, it's like me with my monthly gym membership. Just because I'm paying regularly for the monthly gym membership doesn't mean I'm taking full advantage of my monthly membership.
Right. Or all the different apps that I have subscriptions for, and I get a bill on my credit card and wonder what's going on there.
Sure. We all know that there's so many conditions that have there's no symptoms. The patients oftentimes have no idea that they have something as common as hypertension. We know 95% of hypertension has zero symptoms at all. But we do need to move. We do need to move more towards the middle. I think that the primary care doctors who are at the one extreme need to understand how to be able to communicate with the people at the other, because the people at the other end, guess what? They're like us too. We were all trained in primary care. We're good doctors in a system that wasn't made for us.
It was Marissa from the U.S. Senate Finance Committee. I'm sorry, I don't remember her last name. She was talking about that. They've got bipartisan support in the Senate to work on healthcare and primary care. But what they're realizing is that it is more longitudinal. It is more chronic care rather than episodic care. I mean, when Medicare was invented, it was to take care of people with sort of catastrophic conditions. And now it really is turning into more of a health care maintenance model to take care of people for a longer period of time. So the models have to change. And then I think it was one of the large employers that was there was talking about they need to change the tax code, right? It was Boeing. Boeing would like to give everybody direct primary care, but more than, I think they said something like 40% of their patients are in high deductible health plans. They can't give direct primary care if somebody's in a high deductible health plan, or they can't make a payment for the HSA if they're in a high deductible health plan. Yet they know that they get 20% decreased cost if the employees have access to direct primary care. So we're going to need some help from the legislators to allow some more flexibility in these models of care, realizing that the old model by itself is not getting the results we need, yet those are the right doctors to help us get that care. We've just got to take off some of the shackles to let them run a little bit faster.
We still have a long way to go, although we have made incredible progress with associating the social issues that cause all these medical problems. But I think that's one of the main hurdles and I feel like we're getting better. I feel like that's another big bright spot, is that there's an increasing number of people who value addressing the social issues. You know, the other developed countries in the world, they view the social issues completely different from the way that we do here. We still have that, okay, only use it if you need to use it, and the costs are whatever the cost will be, rather than just nipping the problems in the bud in the first place. I feel like there's a couple of these negative variables that are driving some of these positive movements. Like, we wouldn't have had them had there not been this situation where we have a decreasing number of primary care doctors, increasing number of primary care doctors retiring, the rise of nurse practitioners and physician associates. You know, we have less than 100,000 family doctors, with 2 out of 5 nearing retirement, and almost 500,000 of the nurse practitioners and physician associates, who originally the thought was that most of them would end up going into primary care. And we're seeing an increasing number of them not going into primary care.
Right. I think it was Andrew Bazemore making the comment that there is not stability in funding, either in the different models of care or the amount of money. So it's very difficult to get medical students to choose primary care when they have $300,000 in debt. But it's also very difficult to keep the different team members, whether they are nurse practitioners, physician associates, social workers, RN case managers, or even medical assistants. As I recall, he talked about one of the most disruptive things in his personal practice had been when his medical assistant of 9 years left. Now, she didn't leave because of money. Her husband was in the military and was transferred across the country. But he just talked about how important these different team members are. But especially when you lose one for an extra 50 cents or $1 on the hour, it makes a huge difference to the patients that they've developed these relationships with.
Yeah, because the people who are operating within the healthcare delivery system, for most of them, it's not a job, it's a calling. And so, you know, I know it started off by talking about the doctor-patient relationship, but it's really restoring the core relationships, the doctor-to-doctor relationship, the doctor-to-team relationship, and of course, the doctor-patient relationship. You know, we used to talk about that book, Patients Coming Second. At this point now, especially with physician burnout being where it's at, the support staff turnover situation being where it's at, where funding situation being at, probably we should talk about the patient's needs coming third, because what good are we to the patients if the doctor to doctor relationship is awful? I mean, if the doctor to doctor relationship is not strong, and you've got patients waiting 4 to 6 months to see a specialist because the doctor-to-doctor relationship has become so siloed. I mean, what good are we to the patients, and how frustrating that is for the patients. And then, of course, if the doctor-to-team relationship is not strong, and you have doctors doing the work that other team members could be doing, that would also delay access to primary care. So I think we're at a point now where we used to talk about, being in agreement that the needs of the patient should come second. All right. But I think now we probably need to focus on these three core relationships. So we got to have a strong doctor to doctor, doctor to team, in order to be able to properly get back to what we need to do, which is restoring the doctor to patient relationship.
Right. And I think I mean, we're still talking about being patient centered, right? It's like when you go on the airplane with your wife and four kids, if the cabin depressurizes and the oxygen goes out, it's imperative that you get your mask on so that you're then able to help each of your kids get their mask on. So it's imperative that we take care of the doctors and team members so they can take care of the patients. What we seem to be getting into is an environment where the doctors and the team members are beaten up by the administrators saying we've got to do all of this for the patient, which you're right, we do have to take care of the patients, but boy, we've got to take care of the team members so they can take care of the patients, because we got to assume that everybody who comes to work here wants to take care of the patients.
Okay, so in that situation, first I'd have to put the mask on myself, because what good am I to my wife and children if I don't put the mask on myself first? Next, okay, this is for my wife, I will put the mask on you next. And then after putting the mask on my wife, then we both put the mask on our children.
Because you need your wife to help you take care of the children. Yeah.
That's right. So then with our three core relationships, the first would then need to be the doctor to team relationship. Second would be the doctor to doctor relationship. And then third would be the doctor to patient relationship.
But with the ultimate goal of providing the patients with the best possible care.
Absolutely. And that's why it's so controversial, because, how can you say, because, it goes against our reaction would be to provide the oxygen mask for our children. Just like we all got into this profession to look after patients. But what good are we to the patients if we can't take care of ourselves, if we can't function? Thank you, Dr. Dan. That was great. And my wife would love that answer too, although I think she'd want me to put the oxygen mask on her.
Well, and I've got to say, it was exciting to be there with so many going everywhere, from the community health centers to the small practices, the direct primary care, to the large insurers being represented. And it was David Merritt from Blue Cross and Blue Shield who said, we revere primary care and primary care physicians. I mean, that was, it's interesting, a huge group of insurance companies talking on a national stage about the importance they place on the access to primary care for their members.
Well, it is refreshing to hear, but I'm on the side of, we've been hearing things for a long time. Now we want to see some action, and if we don't see some action, we're going to have to make that action for ourselves. The theme, seeing the possibilities, we heard a lot. We heard a lot during the conference. I think one of the other points was being able to just openly talk about the doctors. Most of primary care is still based in fee for service, making tiny margins, 1.5%, 3% margins. And I like the example that you gave during the interview with Liz Fowler about the gym membership.
Right. Yeah. So my gym offers the ability to take classes. I want to say that it's $12 a class, but once you go over a total of $25 spend a month, then you get unlimited classes. But they don't lock you into a long-term membership paying $25 a month forever. They give you the best rate. So whether it's cheaper to pay by the class or the number of classes, then it's always whatever works best for the member for the month. So as we're trying to get more people into these different prospective payment models, these risk-bearing models, value-based care, it would seem to be natural, because as a group, doctors are risk averse. We're not trained to take risk. So how about letting people work in the model and paying them by the one that would be most beneficial to them on any given year. But if next year things change and they would be better in a different model, don't penalize them because they had a good year. Help them stay afloat and then encourage them to keep moving forward. I don't know what the answer is. That sounds awfully simplistic. I think we do have to look at how we can help people moving forward.
Yeah, but Dr. Dan, if you look at the established practice, the established primary care fee-for-service practices, right, who are still predominantly in fee-for-service, and then you look at the newer companies, the new organizations that are getting into these heavier risk-based contracts, the variable that the established practices have that the newer organizations don't have is the trust. The trust. I think about, we had one doctor who was my doctor for my most of my life until I left my home, was one doctor. My mother had that one doctor who she still reaches out to. And so these practices have the trust that it takes us a few years to earn as we're scaling. Those of us who are out there, scale, they have the trust. So what you're saying would allow them to be able to properly safeguard that trust and get into a model where they already have the outcomes. I'm sure that for those practices, if they had the resources, they would have even better outcomes for their patient population. So that suggestion that you made, it sounds simple, but it works. It works because the world that these doctors are living in, they have the trust already. The frustration that the patients have is the time it takes for the referrals. There's a long wait for certain specialties. There's a long wait for new patients to come into the model, but that's because of the financing structure. It's not because the doctors are heartless and don't want to help look after a patient. Of course, the doctors want to help, but they're confined right now with the current payment model.
Right. And I think the other thing is, as doctors are moving into the models, they are going to want, especially if you're like you grew up in a small town, if your doctor, he would be reluctant, and I'm assuming it was a he, I don't want to be sexist here, he would be reluctant to hire case managers or community health workers if it was only going to be a two or 3 year model, because he's hiring neighbors, he's hiring friends, and now he's not going to be able to pay them long term. And so now he wants to wait and see how it works out. Yet to move this innovation forward, you need a way to get that prospective payment there and know that it's not going to go away, and you're not going to get dinged because you have a bad year and you have to fire. It's one thing if you're a large corporation and you need to have a reduction in force. If you're an individual practice in a small town, it's going to be pretty painful for everybody. And you're getting rid of your kids, friends, family members in your practice. That would be pretty tough.
The policymakers need to pay attention that in these newer models, for the elected officials, especially in the older models, their skeletons crew, small amount of support staff to look after thousands of patients. In these newer models, because they're team-based models and they have additional resources to be able to look after all the social issues, especially that drive a lot of the health outcomes. Instead of having 3 or 4 support staff for a panel of 2,000 patients, when you start talking about having 30 plus support staff looking after a few thousand patients, now the primary care delivery system becomes a significant driver of voters and tax generation and all the stuff that helps move our political system forward.
Then you've got to figure out a way to help drive that down to the primary care practice level. We've talked many times about a large percent of practices are owned by health systems. So even if Medicare changes the payment model, when that money goes into the large system, then it's sort of how the money actually gets routed to the primary care practices can be quite variable, and there can be a pretty big drag as it goes through the system. I mean, I think it's natural in any system when you have a trickle down system, there tends to be a lot of dispersion on the way down. And I'm not blaming the hospitals, I'm not blaming anybody, but you've got to be pretty creative how you get that money to the point of care.
If we've seen anything in history, whenever there was anything that was economic, financial, with, hey, eventually it'll end up getting down to wherever it needs to get to and things will just find a way of working out. It has not. That has not, which is probably why the rise of the direct primary care movement has happened so rapidly and really, quite frankly, so successfully. Well, so as we wrap up, if you had to say one key takeaway from this year's Primary Care for America meeting, if I had to pick one or two, I would say that number one, it is so refreshing that despite all the challenges facing our profession, that there's still such optimism between amongst those of us who are there fighting that fight. Seeing the patients, we know that it's not the patient's fault. And I also feel like there's an increasing number in the communities realizing, hey, it's like what the person from Humana said about her mother's doctor. Her mother has a great doctor just working in a system that's not a fair system for the doctor. That we're figuring out ways to move things forward.
I would agree with you. I think it was interesting to hear so many smart people from so many different areas that are really working on the genius of the and, how to have the relationship and provide the great care, how to be efficient and financially sustainable, how to have the individual relationship and the team relationships. I mean, it's just, I've got real hope that things will keep moving in the right direction.
Yes, it's no longer just talking about increasing access, but we can increase access and also make it effective as well. What are your thoughts on PrimaryCare24? See the possibilities. You've heard ours, now we want to hear yours. Email us at faiselandfriends@gmail.com and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.